Good morning and welcome to everyone, both in the auditorium as well as on Zoom, for this very important meeting. I thank Roseann, Tim, and our Genomics team for not only organizing this symposium, but also the collaborative research work they are doing internationally. This is extremely important. I'm really proud of our genomics team, and I'm happy, they're also part of our Department of Psychiatry. And, they are doing a number of great working with other departments, even within the institution, like neurosurgery and cardiology and metabolism. So they have a big footprint on our campus. As you heard, I'm also the president of the American Psychiatric Association. This is the world's largest psychiatric organization with 39,000 members, and we have a lot of international members. So we really think of it as a global organization, so which is quite pertinent to our collaborative approaches that we are discussing. No disclosures. I just want to kind of bring home some aspect of what we are talking about. Psychotic disorders, as we know, the genetic component is very important, but at the same time, that's not the only story. There is gene environment interactions, which manifests itself by epigenetics and also in other manners, by biological processes and psychological processes. So I like this study because this illustrates it. This was done in The Hague in the Netherlands, and it basically looked into incidence of psychotic disorders in the immigrant population compared with the native Dutch. And they found that, in many communities, people of the same ethnicity and culture, they tend to cluster together in some neighborhoods, and then there are other neighborhoods where there are not that many. So here, the predominant immigrant groups were from Morocco, Suriname, and Turkey. And so they looked into the incidence of psychotic disorders in people who lived in high ethnic density neighborhoods. Basically, there were more people like them, more Moroccans or Surinamese or Turkish in the neighborhoods, and compared it to the incidence in people who lived in other neighborhoods which were predominantly white. There were not that many people like them. And they found that in people living in low ethnic density neighborhoods, their odds of psychotic episodes were much higher than, obviously the native population, but also much higher than people living in high ethnic density neighborhoods. And that's not the only story. It's not simply all immigrants are the same. We all know there are differences among immigrants, and one of them has to do with discrimination for various reasons. Some ethnic groups get discriminated against more than others, and they found, that the incidence of psychosis correlated with this discrimination. Obviously, this is correlational, so in terms of pathophysiology, one can only speculate. But Moroccans, who faced the highest discrimination, Moroccan immigrants, they had the highest risk of developing psychosis in low-density neighborhoods compared to Surinamese and Turks. And what's interesting also is we do know that this possibly causes epigenetic changes because the risk gets transferred on to the children of these people. So that's a fascinating thing. So I think, that is a good segue to talking about why global collaboration is important. There is obviously genetic differences among different groups, but also the environment and interplay and epigenetics are quite important. So with that, I thank you all. Again, I look forward to a very productive symposium and collaboration. Thank you.
Hi, I'm Bigdeli, assistant professor at Downstate, acting director of Institute of Genomics and Health. and I'm jointly appointed at the Brooklyn VA. And I'll be talking today very briefly about some ongoing big data initiatives around genomics and schizophrenia. No disclosures, a necessary disclaimer. So, very briefly, schizophrenia is a complex, heritable, and multifactorial disorder. Famously characterized by positive symptoms, but actually at its core, characterized by profound cognitive and social deficits often. Critically associated with both increased number of physical comorbidities as well as earlier mortality, to typically like 10, 20 years on average compared to the general population. And although there has been progress from genomic finding, large-scale genomic studies, there's limited generalizability of these findings, and none of these findings are really clinically actionable. We're talking about small effect sizes, which I will talk about a little bit more in a moment. Now, I should acknowledge that we'll be talking mostly about common variant studies, that is, studies of variation that exist in global populations. It is true that there are large effect variants, but they don't explain most of the psychosis that occurs in the general population. I mean, these are typically syndromic presentations that have a kind of typical clinical syndromic presentation. So in the context of genome-wide association studies, to date there have been 270 physical loci, like distinct chromosomal regions implicated in schizophrenia. This is mostly based on large-scale studies of European ancestry populations, which is a problem, and we'll talk a bit more in this talk. And our most promising tool, that is polygenic scores, which aggregate the effects from GOS, they can explain maybe 10, upwards of 10% of the variance in risk, but that amount of risk explained falls off precipitously when you apply them across populations to the non-European like groups. So also, and the kind of subject of today's talk is that despite schizophrenia related psychoses occurring in every population, they tend to be more frequently diagnosed, as acknowledged by Dr. Viz earlier, in certain groups. In the United States, that is most famously individuals of African ancestry, particularly African American men. And today I'll talk about the findings that we have to suggest, like what might be underlying those diagnostic biases, and and the fact that all biology points to basically being the same disorder, of course. So starting us out, I think more than a decade ago, 3 letters in Nature describing one singular hit in the major histocompatibility complex on chromosome 6p. A lot of effort, thousands of cases, a single locus. Now, in a nice demonstration of making lemonades out of lemons, Jean Purcell et al., as part of the International Schizophrenia Consortium, demonstrated for the first time that this polygenic theory, which had first been put forth by Ronald Fisher and had been applied to schizophrenia by Irv Gottesman in the 60s, actually it does work. If you take individual variants that don't themselves achieve statistical significance and you add them up and you look at an independent cohort, you can find that you can explain some of the variation in risk. I alluded to 10% or more. That's risen with increasing sample size. At the time, we're talking about going from the ISC cohort to an independent European ancestry cohort, explaining around 3% of the variation. Now, a striking thing about this figure on the right here is that at the time we were doing better predicting across diagnoses within European populations than we were predicting across populations, trying to predict schizophrenia in the smaller MGS African ancestry sample, which is a bit disturbing. Now, moving forward, with increasing sample size, we've seen more and more hits, more and more. And the last large-scale kind of installment from the PGC yielding the aforementioned 270 loci. Now, if we look at, and strangely, it does not appear that all of the points are showing up on this slide, but if we look at the power curve for the effects, those 270 SNPs, which are meant to show up along that gray line on the left, as measured in European populations, and you overlay the estimates from currently available African ancestry populations, which are shown in green, you can see they don't sit exactly on that line, and there's quite a bit of noise there. So what we're seeing is actually that effect sizes as estimated in European populations do not generalize so well to European populations. And there's another hint in here about copying and pasting PDFs into your presentations and them not showing up properly. Now, why is that a problem? Why is that surprising? Well, at bottom, we are all relatively recently from East Africa. That is, human beings are a very young species in an evolutionary context, and it's only really in the last 50,000 years or so that we have, that various groups have migrated out of Africa and colonized the entire world. So there's actually very limited amount of genetic variation, between any one of us, any two of us rather. So why should there be such stark differences in terms of generalizability of genetic effects? This is an issue and surprising. So what are some critical obstacles so far to our progress? I think most critically is sample size. And why? That's a multifaceted question. There's a reasonable circumspection in a lot of groups about participating in especially U.S. federal funded genomic studies. We can think of the question of blood quanta in Native American populations. There's a necessity to engage in research and build trust with local communities in order to actually do this research in a beneficent way. Also, the statistical methods that we have, and have been trained and driven mostly by available European ancestry data, have not really realized their the necessary potential as applied to the much more genetically diverse and complex genomes of often admixed populations in the United States. On the right here, we have a representation on the far right of global ancestry proportions around the world, and then on the left by disorder, and this needs to be updated probably, but from our colleague, Dr. Peterson, a representation of how those populations have been represented in GWAS, and we see that they do not match, right? It's kind of visualizing that Eurocentric bias. So we have an opportunity working at the VA, which is the closest thing we have in this country to socialized medicine. I mean, we talk about American excellence. That doesn't really apply to being able to go to a doctor, whenever you want, or so easily. But if you were ever active service military, you can go to the doctor. You can go to the VA, whenever you want. People volunteer self-select for VA healthcare utilization, but this is by far the largest integrated healthcare system in the United States, serving over 9 million registered individuals across over 150 different medical centers, and embedded within the VA research environment is a landmark study started by Phil Harvey and Larry Seaver in 2007 or 8 that leveraged a multi-site clinical trial funding mechanism, the Cooperative Studies Program, to amass around 10,000 cases of very well-defined schizophrenia or bipolar I disorder. We're talking 4 hours of in-depth interviews, including both structural clinical instruments to get gold standard diagnoses, cognitive assessments, assessments of PTSD symptoms, suicidality, and also, critically embedded within the very large-scale EHR of the VA has. And, more recently, coming out of CSP in many ways, is the Million Veteran Program, which is the largest U.S. biobank with over 1 million individuals enrolled, and in the current genetic data release, over 660,000 with whole genome data. And we have the privilege of working with this very large data set, and we can answer some interesting questions, I think. So just giving a shout out to our assembled teams. I think the main sites here working on schizophrenia are our very own Downstate team, Mount Sinai, University of Miami, and the Coordinating Center for Cooperating Studies Program at the CERC in West Haven. So leveraging those gold standard diagnoses that we have, we actually can show that we can predict using EHR pretty reasonably well the known diagnosis, the true diagnosis, just using ICD codes. We found that using 2 ICD codes for schizophrenia did well enough, as well as for bipolar disorder. You can see on the left and the right actually that that medication use is actually rather non-specific for antipsychotics compared to mood stabilizers. That's not entirely unexpected given how widely antipsychotics are prescribed for a variety of different psychiatric symptoms. So this is showing that we can leverage EHR to reasonably define schizophrenia, when we don't have the benefit of an in-person interview. Now, what predicts misdiagnosis? Well, among those individuals who we knew their actual diagnosis, and with this example, that being bipolar I disorder, we looked among those that actually had in their chart a schizophrenia diagnosis. So again, we know based on the interview that they had bipolar I disorder, what predicted that they, or what factors predicted them having also a code for psychosis or a code for schizophrenia at some point earlier in our medical history. And we ran this, simple like logistic regression model, including both some demographic variables as well as a measure of everyday functioning, namely the UPSA brief version. And what we found pretty strikingly is that being, an African American male, more than double, with confirmed bipolar disorder, you're twice as likely to have received a schizophrenia diagnosis at some time during your medical services utilization of the VA. So why might that be? Well, we wonder, and we're trying to figure that out. If we take our polygenic scores for 3 disorders, we see this disparity come through in terms of the overall prevalence. Now, what I want to point out here on the far left is that if we take everyone and score them, 660,000 people. In this example, this is about 400,000 European ancestry individuals, 125,000 African ancestry individuals, and we just rank them and say, what decile of risk are you in for currently indexable genetic risk of schizophrenia or bipolar disorder or major depression? You see that at the extremes, as expected, if you compare the top 10% to the bottom 10%, you do see a significant difference. That is, as expected, a higher prevalence of schizophrenia among individuals with a higher genetic loading for schizophrenia. That said, the y-intercept, right, in the average prevalence is quite different, and it's much higher than we would expect in African ancestry populations. Now, the important thing here is that it still works. That is, we are not seeing that the label as applied to different populations all of a sudden makes the genetic or the hypothesis that is at least partly genetically driven go away. It is still very demonstrably genetic, but there is something else going on that's driving these differences in case prevalence across populations. And that's probably most striking for major depression, which raises questions about how these diagnoses, how these ICD codes are actually being applied. There certainly should not be a prevalence of 50% in any population, military exposed or not. If we take this a bit further, and we ask, okay, well, when did individuals actually serve in the military? We actually see that although it is, based on self-reported service period, by epoch, still, demonstrably genetic. That is, at the extremes, you have a higher prevalence among people with higher genetic loading. We can see that over time, generationally, there have been differences in terms of how often, in the prevalence, of how these, of schizophrenia diagnoses across populations. See that these actually peaked in the era of the Vietnam War and in the era following that, but actually over time actually has come down. So they're still higher in African American veterans compared to European ancestry veterans, but not to such an extreme extent as seen among those that served, in the 60s through Desert Storm. Comparatively, we see that bipolar diagnoses, probably this is, again, this is still looking at schizophrenia as a PRS, but we're looking at the prevalence of having received a bipolar diagnosis over time. Those have been steadily increasing, at least over time, or at least are applied more often now than they had been before. Now, what might explain these differences over time? So what we're showing here is in the overall MVP cohort, their year of birth, and then, if you see highlighted here in yellow, are individuals that were born during the years that would have meant that during the Vietnam War, they turned 18, they were eligible for military conscription. That is, the era of the Vietnam War is characterized by quite a lot, probably the greatest degree of military conscription among, specifically young men. So we see that over time, the representation in the U.S. military has changed pretty substantially, right? Like if you look, for instance, the distribution of, how the bimodal peak, or almost bimodal peak in terms of African ancestry veterans, males, shown in the center plot, we see that, from the draft period onwards, we have an overrepresentation of African Americans in the U.S. military. In the upper left-hand corner, we see the same distribution for female veterans, of which there are, I think, probably around 70 or 80,000, currently enrolled in the Million Veteran Program. Women were not eligible for draft. They were not drafted specifically. So actually, you see that peak actually follows that period of, that yellow highlighted period that indicates, coming of age during the orange period and being eligible for conscription. So could that explain part of it? Well, looking now not at genetics, but at the self-identified identity, we compare patterns in diagnosis between male veterans and female veterans. We actually see an identical pattern. So we cannot blame necessarily the draft specifically, because there was some question about, could it be that individuals that were not, well suited for medical military service, were being enrolled into the military, and you might, reasonably expect that had to do with the draft, but women not being eligible for a draft and still showing this pattern over time, right, with an increased rate of diagnosis of schizophrenia in these populations, but also in European populations too during that time. So obviously we're seeing something social and possibly some changes in terms of like who is signing up for the military, the transition to a volunteer force, the fact that this also represents, employment opportunity. So there are social contexts here that are relevant but not directly measured, or we're starting to get some hints for. Now, very briefly, I know probably over time, I want to say that our large-scale genomic analysis within the VA suggests that, or at least very clearly demonstrate that on the left here, that the measurable variance associated with schizophrenia risk is identical, is exactly the same in European and African ancestry veterans. That is not more heritable in any one population or another. That said, there is more genetic variation in the genetically more diverse African diaspora populations, so there are more variations, that is polymorphisms on average in an African genome than a European ancestry genome. So when you adjust for that on the right, we are seeing that a smaller number of SNPs, those that are measured in these large-scale GWASs that are predominantly European, explain more variation. This is basically highlighting a challenge that really we need to be doing more to do deeper sequencing, to have better coverage of rare variation, and that a lot of our research findings to date in genetics are, heavily biased towards European patterns of linkage equilibrium, et cetera. If we take the enrichments in GWAS as run, genome-wide association studies as run in European populations and African ancestry populations, and then look at transcriptional patterns in specific cell types, and look at enrichment of our GWAS findings in patterns of transcription by cell type, we see that actually that they mirror one each other almost identically. Of course, we have less statistical power in African ancestries than we do in European ancestries, but we look across all these different cell taxonomies on the left here. We see that the effect sizes, as shown down here on the bottom right, are almost identical, sitting almost perfectly on a line. That is, at the cellular level, the biological basis is not really distinguishable in one population or another. Not that we expected it would be, but we are, I think, for the first time demonstrating that, I think, resoundingly. So what does it take for a trait to be polygenic? Well, we're talking about something that could be genetically influenced, but it's not nature versus nurture. It's both. It's nature and nurture. And actually, nurture or environment, which is a much harder thing to quantify, a much more difficult thing, to put our finger on than genetics. Genetics is the easy thing to measure. Environment is the hard thing to measure. So in order to actually study polygenic traits, we probably need to do a little bit more than just amassing large numbers of people and then just genotyping them. I like to borrow from this analogy from genetic counseling, to kind of demonstrate that we each have a different complement of risk factors, both inherited and acquired, and the culmination of these, the confluences of these, are what gives rise to the manifestation of of illness. Now, what's shown in this kind of jar model, that these environmental variables that are shown in these orange triangles, these are the ones that are really hard to measure and that are not commonly measured in large-scale genome-wide association studies, which are primarily focused on large sample sizes and just genotyping. What can we do to actually measure those? Well, here we have our introduction to our honored guests and speakers. We are proud to announce I would say new collaboration. There's been a partnership between SUNY Downstate, University of West Indies in Northern Trinidad, and the University of Ibadan in Nigeria since I think 2018, when we started out. And we recently received a large-scale, R01, to extend the work of the Intrepid study and add a cross-sectional component for comparison. And this will be described by our guests, Dr. Gureje and Dr. Hutchinson. We're very honored to have with us today. And just very briefly, really the beauty of the study design put forth in the Intrepid study is led by Professors Gureje and Hutchinson et al. And their colleagues in Chennai, India, and in London, is that by studying in an epidemiological way, incident psychosis, that is psychosis as it emerges, and not just in its opportunistic way, but the large scales, GWASs have done to date, we can potentially uncouple the social context, for example, the social context in the United States being these racialized disparities in diagnosis, from the actual phenomenon of schizophrenia as it emerged, and actually study the natural history of disease exactly the same way in very different environments. And our goal is to extend their previous work, to create a matched cohort of the inpatient treated patients, and also to create some localized biobanks to actually not just limit our research to risk and susceptibility, but actually to extend that to studies of physical comorbidity social determinants of health, and how the the illness develops and it changes over time. And with that, I will thank all of my VA colleagues, in particular my bosses, Dr. Harvey, Dr. Russo, Dr. Aslan, and all of our team members that contributed to the large-scale GWAS that I presented results from today. And with that, I will thank you and step aside. Thanks.
Okay, good morning, everyone. My first observation when I came to the US yesterday was that everyone was looking relatively very calm, not stressed. And I was wondering whether we outside America are actually more stressed about your election than you are. But possible. So it's nice to see you all looking very calm, and even though I know that the situation is really very. So thank you for putting this together. The talk that Dr. Ramaswamy gave and team sort of set the stage for the reason for the need for this kind of collaborative cross-cultural studies. But actually, the Intrepid research program was started on the basis of some previous epidemiological study, especially the one that was conducted by the WHO several years ago, in which they showed sort of similar prevalence or even incidence of schizophrenia across different settings, but also show that their conditions had a better outcome in developing countries. So that was really the basis for the initial attempt for us to put this study together. That we've given the title International Research Program on Psychosis in Diverse Settings, which we have now conducted. We've conducted phase 1, phase 2, and now we are in phase 3. The phase 1 was conducted over 3 years, really more to sort of set the stage and develop these instruments and the methodology. And then we went on to conducting the second phase, this Intrepid 2, with the broad aims that are listed on this slide to compare the incidence and presentation in the 3 settings where the study is being conducted, to explore the 2-year cause and outcome and the pattern of help seeking and the impact of the illness, as well as to track some other both antecedents and comorbidities and also consequences of this condition, particularly physical health problems. So we are recruiting. We're now in Intrepid 3, which is really basically to follow the Intrepid 2 sample and track the 6-year outcome. But the incident study itself, where we recruited the people from these various contact settings in those 3 places. We use popular sector, by which we meant people who might not have been taken to anywhere to hospital, who are sort of in their various homes. We use public mental health systems, tracking all the new cases presenting in those. And as you might see, you will see later on, we will also very importantly track cases from traditional and faith healing facilities in those settings. These are some of the pictures of where we did this, and a particular catchment area. Kanchipuram in India, that was the area that we chose, mainly rural, outside of Chennai. In Ibadan, we use both local and urban areas around the metropolis of Ibadan, catchment area around that. And in the third place was in northern Trinidad. And these were the cases we identified. So the catchment area we selected on the basis that we should have population at risk of at least 500,000 people, adults. And so we were able to select, to identify this number of cases in those 3 catchment areas over the 2-year period. And as you can see from that, most of the cases in Trinidad were identified from professional treatment settings. In Ibadan, sort of equally distributed between professional and folk, that is traditional faith healing homes. And in India, you see that as many as 80% of the cases were identified from neither of those 2 places. These were people who had not presented to any of those settings, even though they have been ill for quite a while, as you will see in the various. So these are some of the characteristics that make this study really quite interesting in terms of what we can learn from it. And these are the sample characteristics of the patients, both in terms of the age, gender, and also in the distribution of the diagnostic categories. As I mentioned, we were also interested in tracking how long they've been unwell for before presenting. And so you can see a very striking picture here that the mean duration of untreated psychosis in India was more than 7 years, almost 8 years, and about 3 years in both Trinidad and Nigeria, where in any case, most of them did make some attempt to seek care in Ibadan, both from traditional and public service settings. But in India, as I mentioned, a lot of them were not in care, and they have been unwell for almost 8 years by the time they were recruited into this study. So let me give you a few findings from the physical health. My colleague, Gerard, will be talking about the profile of use of substance, especially cannabis, in the setting. So we were interested in tracking this physical health, and we used these measures listed on the slide. So we measure their blood pressure, their took blood for that, so blood glucose, lipid profile. We tracked some selected infection, and did their BMI. So when I talk about malnutrition here, really I'm talking more about undernutrition, because that really was what we found. So that was we define as put on that slide. So basically, this is the profile of the distribution of the physical health in terms of hypertension, diabetes, hyperlipidemia, and head injury, as reported by the. And you can see that the patients in Trinidad had a significantly higher rate of all of these conditions than the ones in Ibadan and India. The reverse is what? Let me see. I think I've gone too far. Yeah. So the reverse is what you will see when it comes to infection, malnutrition, and anemia, where now you find that the cases identified in both in Ibadan and India had a much higher rate of all of those conditions. So hypertension, hyperlipidemia, higher in Trinidad, but infection, anemia, and malnutrition, mainly undernutrition, much higher in Ibadan and India than in Trinidad. Now, I didn't mention that for these cases, we identify controls. So that these were individuals without psychosis who lived in the same neighborhood as the cases and had about the same age of the same gender. So we had some kind of case control comparison of cases and controls. And the findings will be what I will be presenting next. And then in Ibadan, we find that basically no difference between the cases and control in terms of cholesterol, diabetes, hypertension. In India, the same was true. Not a lot of difference between cases and control for those conditions. And also the same for in Trinidad. So this indications of a lifestyle and dietary profile, habit, cholesterol, diabetes. But when it comes to infection again, now striking difference was seen in Nigeria, where the cases they were much more likely to show evidence of infection, to be anemic, and then to have to be undernourished in terms of malnutrition that we define there, significantly so compared with control. And the same was true for India, even though that difference was only significant in terms of undernutrition, which was much higher among cases. These were, as I mentioned, incident cases that had not been in receipt of any kind of treatment. No different in Trinidad in terms of those conditions, inflammatory protein, anemia, malnutrition, and infection. So basically you see that in terms of the countries, in Trinidad, it was a much higher income country than the other two, had a different profile of physical health condition compared with Ibadan and Nigeria. And these reflected more about the social circumstances of those two countries rather than any kind of previous exposure to treatment. So that is something that we are going to be trying to focus on when we do the analysis of the 2-year outcome, the data of which we already have. And as I mentioned, we are now collecting data for the 6-year outcome, and we're going to see how this pans out. And the reason why all this is also very important is in the context of what Tim has described, which is that we are now able to expand this considerably with PAD, and to see to what extent some of these differences also had some kind of genetic underpinning, which a much larger sample will allow us to begin to explore. So my colleague will be talking about what we found in terms of the use of cannabis and how that relates to the occurrence of psychosis.
Okay, good morning, everyone. Thank you for the opportunity to talk about our work in this context. Thank you, Tim, for the invitation. And to follow up on what my colleague, Professor Gureje, said, the Intrepid study, in seeking to compare these diverse settings, also sought to distinguish in terms of the factors that are associated with psychosis, what might distinguish the various sites. 2 points about Trinidad. One is that it is a relatively ethnically diverse country, specifically having equal percentages of descendants from Africa and southern India. So our population is approximately 40% African, 40% Indian, and 20% mixed and European and Middle Eastern. So in that sense, it also allows for comparison to source populations, so to speak, in India and Nigeria, to look at the incidence of psychosis and how it compares in ethnic groups. And of course, this relates to the comments of the chair, the head of psychiatry here, about disparities in the incidence of psychosis and schizophrenia. And particularly, as Tim mentioned, the fact that these disparities seem to be linked more so to immigrants from the African diaspora as against immigrants from other countries. So one of the factors that emerged from the work in psychosis is the use of substances, specifically cannabis. So that's what I'm going to talk about in the context of the rates. You would also have noticed from Oye's presentation that the rates in Trinidad were quite higher, significantly, to a significant extent compared to India and Nigeria. And again, we've been trying to explain why that might be so. Right. So, well, Oye's already talked about the study itself, the inclusion criteria being the adult population resident in the catchment area in the presence of a psychotic disorder as defined by ICD. The instruments in terms of those that are relevant to this discussion, the symptom and diagnostic instrument is the scan. We also use the socio-demographic schedule from the Medical Research Council in Britain. And for substance use, we use the ASSIST questionnaire, alcohol, smoking, and substance involvement screening. And you see an outline of the ASSIST, the questions that are asked below that. And the exposure variables we looked at were lifetime cannabis use, the frequency of cannabis use, a high ASSIST risk score, and the age of first use. All of these have been associated with psychotic presentations, hence the choice of those particular measures for exploration. And on the left, you have, well, your right, my left, you have the statistical analyses that were conducted. And these were the results. So, as you see, the rates of psychosis were considerably higher in the sample from Trinidad, 59.1, compared to 20.7 in India, or Kanchipuram, and 14.4 in Nigeria. Even there's some interesting disparities. In India, you will see that, and which is unusual for most psychotic epidemiological samples and studies, higher rates in women compared to men. And in Ibadan, you see almost similar rates between men and women, whereas in Trinidad, the rates in men were significantly higher than the rates in women. Also, interestingly, in Trinidad, the rates among the population of African descent was significantly higher than the rates among those of Indian descent. And just to go back to the disparities literature, one of the things that started me off in this area was working in London in the 90s, and there are startlingly higher rates among patients of African Caribbean descent compared to patients of Indo-Caribbean descent, as well as patients from the Indian subcontinent in Britain. And this is what led to a lot of the work that subsequently happened in the rest of Europe regarding these rates. So the question, of course, is there some particular predisposition to psychosis among the African population compared to the Indian population? Although the results from India and Nigeria don't support that. So this now looks at the age of onset, and again, the age of onset was highest in India and lowest in Trinidad, with the rates being, in terms of mean age of onset, being lower as well for the African population compared to the rest. And this is prevalence of cannabis use. Again, you see significant differences between Trinidad and the rest of the sites, where 72% of the cases had a history of cannabis use. But what is also interesting is that 65% of the controls also had a history of lifetime cannabis use. So although the percentage in cases was higher, there was also a significant use of cannabis among controls. Again now suggesting that the people who develop psychosis, there are particular variations within them that would lead them to develop psychosis compared to controls, or perhaps protective factors acting among the controls that would prevent them from developing psychosis. And for frequent cannabis use, and frequent cannabis use here refers to daily use. Again, significant difference between Trinidad and the other sites. Also much more so in men compared to women, much more so as well in Afro-Trinidadians compared to Indo-Trinidadians. Interestingly, in Ibadan, you would see that in terms of frequent use, again, it was also seen almost entirely in men, and there were no women who reported frequent cannabis use. And of course, just to go back here, you see in Kanchipuram specifically, there was very little cannabis use. Again, we're not clear whether this is a local anomaly, and whether in other areas or districts in India there might be places where there's higher cannabis use, but certainly this was a striking finding here. And then the association of cannabis exposure with psychotic disorder. So comparing Trinidad and Ibadan, so we eliminated India from this analysis because, of course, as I said, the rates of cannabis use were so low in India. And as you see, those who use frequently, those who had a higher assist score, and the age of first use being less than or equal to 15 years, were all significantly associated with psychotic disorder. The numbers in Ibadan precluded any significant assessment of the effect, but certainly in Trinidad it is clear that both frequent use, a highest assist score, and early age of first use, which all have been identified in the literature as being associated with psychotic disorder, bore true for the Trinidad sample. And again, association of cannabis exposure with the mean age of onset, and you see that those who had psychosis but never used, the mean age of onset was older, 30. Lifetime use, the mean age of onset was 25. Frequent use, the mean age of onset was 24. And those with a high assist score, the mean age of onset was 23, showing that the use of cannabis seems to predispose people to develop psychosis at an earlier age. And again, we saw a similar pattern in Nigeria, although the differences between lifetime use, frequent use, and a high assist score were not that significant, but certainly different to and much lower than for those who had never used. So, what does all that mean? There's a high prevalence of cannabis use in Trinidad, higher prevalence among males and the African Trinidadian population. First-time early age users are at much greater risk. The assist score is a useful tool for identifying risk. Based on the interview, many people, or a significant number, 16% of controls, 37% of cases, had previously tried to stop but were unable to. There's also high co-use with tobacco, so therefore the use of tobacco and attempts to deal with cannabis have to coincide. And this is not the first study that has identified cannabis use as a concern. In Jamaica, Frank Knight and his colleagues way back in the 70s, Frank Knight and Timothy Harding published papers related to what they described then as ganja psychosis, which was Knight's paper, and Harding's paper was called marijuana modified mania. And while it was an epidemiologically comprehensive study, they identified the presentation of young males especially who were presenting in disproportionate numbers to the psychiatric services then, the psychiatric unit at the University Hospital in Mona, Kingston, Jamaica, with high levels of cannabis use, and this being a factor seemingly that had predisposed them to develop psychosis. So the association does suggest that cannabis use is associated with the incidence of psychosis. So one of the other questions is whether this is one of the factors that has predisposed the population in Trinidad to have such a higher rate of psychosis compared to that seen in Ibadan and Kanchipuram. And again, this is just reiterating those points related to the age of onset and the frequency of cannabis use. This is a slide about the prevalence of affective psychosis. So one of the other issues in this whole debate around the incidence and variations in incidence of psychosis is whether it is specific to schizophrenia within psychosis or whether it applies to all psychosis, and what are the differences between non-affective and affective psychosis. And again, you see here that the rate of frequent cannabis use in affective psychosis is much higher in the population in Trinidad, although the disparity between the various groups is not as great. In fact, for women, there are higher rates of cannabis use, and the differences between the Afro and Indo-Trinidadians is diminished quite significantly. So again, it does seem here that the use of cannabis has a different effect, certainly in terms of gender, and perhaps also in terms of the ethnic distribution that we saw for non-affective psychosis. So, wide variation of incidence between the sites with the highest rates in Trinidad, high levels of lifetime and frequent cannabis use, and its association with psychosis in Trinidad and to a lesser extent Ibadan. Looking at previous studies, we found that this was very consistent with the European study, which also reported high levels of cannabis use in the areas with the highest incidence of psychosis. So the hypothesis is that cannabis use may account in part for the variations between Trinidad and Nigeria. And of course, this is speculative, and one of the interesting areas is whether there is a genetic component here that either one predisposes some people to develop psychosis in the context of cannabis use, or indeed is it that the genetic risk or the genetic predisposition has a joint effect in terms of the people who have that genetic predisposition are also more likely to use cannabis, as well as more likely to develop psychosis. So with that, I'll stop there. Thank you very much.
Let's go ahead and have the speakers come up, as well as our panel, our discussion panel. Okay, why don't we start briefly by all of us introducing ourselves again on the panel. Dr. Taylor, you want to start?
Good morning. My name is Tanya Taylor. I am faculty in the Department of Medicine here at Downstate and the Division of Infectious Disease, and very excited to work with all of these wonderful people on this panel. I guess I should say also I'm a medical linguistic anthropologist, and I've been doing research in Zimbabwe specifically, but Southern East Africa for over 25 years.
Okay. Good morning. I'm Dr. Ernest Barthélemy. I'm the chief of the Division of Neurosurgery here at Downstate. I'm a trauma neurosurgeon by clinical subspecialty as well as a global health equity researcher, and happy to be here with you all.
Yeah, hi, good morning. My name is Gerard Hutchinson. I am a professor of psychiatry at the University of the West Indies, St. Augustine, Trinidad campus. There are 4, in fact, now 5 campuses of the University of the West Indies. Trinidad is one. I'm a psychiatrist, and my research interest is psychosis as well as suicide. Thank you.
Hi, my name is Iyegbe. I'm an instructor in genetics based at Mount Sinai Hospital. I also co-lead a division of the Psychiatric Genomics Consortium, which is tasked with implementing a developmental agenda for psychiatric genomics on the African continent.
Hi, I'm Ramaswamy Viswanathan, also from BIS. I'm a professor in the interim chair of psychiatry at SUNY Downstate. Hi, I'm Ramaswamy Viswanathan. I'm professor and interim chair of psychiatry and behavioral sciences at State University of New York, Downstate Health Sciences University. I'm also the president of the American Psychiatric Association.
Good morning. I'm Gureje. I'm a professor of psychiatry and the director of the WHO Collaborating Center at the University of Ibadan, and the PI for the Intrepid study in Nigeria, and the PI for the oncoming PAD study taking place across the country and Trinidad.
Tim Bigdeli, genetic epidemiologist, acting director of IGH here at Downstate, and scientific director of CSV 572's Analytics site in Brooklyn.
Okay, so first, are there any burning questions from the audience before we turn it over to the panel? Great. Yes, please introduce yourself too, please.
My name is Marcos. I'm a psychiatrist by training from Ethiopia. I'm currently at Downstate. My question is regarding the physical health, between the general population and individuals with psychosis. I was a bit surprised because I expected the higher proportion of people with psychosis to have undiagnosed medical illnesses, and I wonder if this is before treatment was started, or if treatment would have affected this differently.
Yeah, I mean, it was surprising that they had that level of undernutrition, that this was a relatively young population of sample of patients. And what you saw in regards to hypertension is probably a reflection of that. That if we had people who were maybe in their 50s or 60s, the prevalence of hypertension and diabetes will certainly have been much higher. So in that respect, it's not really a surprise that the rate that we found is reflective of the age of the sample. But I think if you look at the other aspect of it, especially undernutrition, you wouldn't expect to find that rate in people in their 30s. maybe in much younger children, a lot of that you could expect that. But that certainly is a reflection of the social circumstances that these people live in, poverty and the fact that also a high prevalence of infection among them, which will also have contributed to their undernutritional status.
Okay, any other questions from the students? Yeah.
So I saw the question on the Zoom, and it kind of goes along with one of my questions. So my name is Patrick. I'm a PhD student in clinical psychology. And Dr. Ramaswamy, you mentioned the impact of ethnic density. This is something that I'm looking at in my research too, and it's something I find very interesting. So I know ethnic density, for example, in the Hispanic population in the United States is associated with better health outcomes, including reduced all-cause mortality. I'm wondering, when it comes to psychosis, schizophrenia, how, through what mechanisms might ethnic density be protective? Are we thinking maybe it's because of better social support, social structures, connections with others that those are protective against psychosis, schizophrenia, and that ethnic density is a proxy for those more maybe direct influences?
Yeah, the ethnic, living in ethnic density neighborhoods, obviously, it's actually there are two sides, right? The people who are in ethnically light neighborhoods, they are faced with discrimination and also lack of social support, and also it can becomes more complex. Also, identity formation, right? When you are living among people more like you, then you feel good about your identity. Your identity gets validated. So it's really there's a complexity of factors involved in that. Yeah, thank you. Yeah. Can I ask you a question, or are we still taking questions from? I want to, in terms of the cannabis. It's a tricky. Obviously, we know that cannabis affects the brain, but also what about mothers who are smoking cannabis, and while the index patients were their fetus, is there any literature on it?
There is some literature suggesting that cannabis use during pregnancy does affect the developing brain in the fetus, and therefore does affect some childhood markers of development. In terms of that as a risk for long-term, and meaning psychosis or other illnesses that might present later in the life course, I don't think that has been looked at yet. But there's also the element of, which wasn't reported in the study, but what we did find was that in people who were at greater risk for psychosis, their families, meaning their parents or their siblings, also reported high cannabis use compared to those who didn't have psychosis and who used cannabis, meaning the controls who. So again, it'd be interesting to determine if that is how a family environment where cannabis is used frequently affects the impact of cannabis on psychosis. And to go back to the previous question, I think one of the other areas in which ethnic density seems to be protective is the question of disadvantage or perceptions of disadvantage. So people who live in low ethnic density neighborhoods tend to perceive many of the events that happen to them as a consequence of the disadvantage that they feel is pervasive in terms of their social experience. And of course, there's always a challenge in distinguishing between perception and whether that disadvantage is real. But in many instances, when people feel that they're disadvantaged, they're going to experience disadvantage, or they're going to see in their experiences evidence to support that sense of being disadvantaged.
Okay. First, I just want to say those presentations were absolutely wonderful. Thank you. I have a question, I guess, piggybacking off of the gentleman in the audience, which is about HIV. So, in particular, I was curious to know, and I don't know if HIV would be an exclusionary criteria for the work that you want to do, but nonetheless, this is my background, so I'm just going to ask a question. We know that psychosis increases the risk of HIV. And I know that in Nigeria, the HIV prevalence is very low. I know in India, it's pretty substantial. The Caribbean, it's also pretty substantial. And so I was just wondering, in terms of these physical health and this sort of synergism with HIV, which brings a whole host of other comorbidities or multimorbidities, and also profound impacts on cognition, et cetera. And so I was just wondering if all four panelists wanted to just sort of chime in, or I don't know if there was a reason why it was excluded or so forth, but I'm just curious. Oh, I also did have one other question, sorry, which is about in India, you said that there were the majority of the cases sort of diagnosed were through informal networks, and I'd really love to know how informal was defined here, because in India there's Ayurvedic medicine, and so it wasn't really clear, you know, in terms of professional being Western medicine, but like there's a whole nother layer of medicine, which is, you know, I mean, Ayurvedic medicine is another level of professional. Thank you.
Yeah, so I take the second question first. We identified 3 targets for finding cases in the catchment areas. One would be those presenting to any of the health public biomedical service, which could be private or public. So that's one category. The second would be those presenting to non-public or non-formal sectors. And that will include traditional healers, faith healers, whatever the categories might be in the country. I mean, you saw that a few patients even in Trinidad were recruited from that. So in India, it will have been any of their traditional, healing places. In Nigeria, it just happened that almost half of those people were recruited from traditional field. And the third category that we call informal was that we made an extensive network. We developed an extended network of contacts with neighborhood associations, market groups, whatever, in order to try and identify people that they felt might have the problem but hadn't turned up in any place, where maybe locked up in the home, maybe just roaming around the street or whatever. That's what we call the focal point. So we found that in India, a large proportion of the cases that we found had not shown up in any of the other 2 places. Or maybe some will have shown up once and then will not come back. So those were the ones that we describe as, and you could see from the profile of the DUP, the much more than double in terms of the DUP in India compared with Nigeria and India, in Trinidad, which is a reflection of that people were just not availing themselves of any of those kind of treatment facilities in the place where we did this. Of course, if we had done this in urban Chennai, it would have been different. But we did this in some rural adjoining places around. So that's why it's important to put that in the context of where the study was conducted. Now, to your other question, no, there was no exclusion in terms of, we identified, of course, we couldn't screen for every infection. We had the inflammatory protein as some kind of sort of, you might say blunt reflection of maybe people might have infection that we were not otherwise tracking. But I mentioned the one that we did actually track, those ones that we thought were prevalent, including HIV. HIV just happened not to have turned up in the sample. That tuberculosis was there, hepatitis was there, malaria was there, dengue fever was there, and then we had a couple of what they call these conditions, tropical diseases, neglected tropical diseases that we also tracked. So we found a few cases in. No. We were not so much interested in, you know what, it wasn't a survey of HIV. It was a survey of physical conditions among cases. So it was comorbidity that we were. If we were doing a survey of HIV, of course, we would get a lot of, but we were looking for comorbidity among identified cases and their selected controls. So in the cases that we had, we didn't have, maybe there was one case of HIV in Baden or something. That was all. Not the other cases, there were no. So that's the profile. It wasn't a reflection of HIV prevalence in the community. Certainly not.
No,
it was just.
So HIV was not considered as a comorbidity.
It was one of the cases that we screened for. Okay. But like I said, we just didn't find so many of them in that other cases. Yeah.
I just have a follow-up question on this. In terms of case detection, formal or informal, part of the issue is the tolerance of the society for different kinds of behavior. That can, if society is family or surroundings are intolerant of behaviors, they are more likely to seek help. Do you think that played a role in more informal cases being detected in India?
No, absolutely. I mean, maybe in all the other three places, because I mean, if someone had psychotic problem, and the neighbors or people around them did not identify that as a problem, of course they wouldn't have been. We wouldn't have been sensitized to their presence. So, but I'm not sure to what extent that will have been a major part of the cases we found, because after doing all of this survey, we then did what we call, we were trying to find leakages. We did an extensive leakage study in which we were trying to see whether there were cases that we should have identified that we didn't find. But that's not to say that certainly there will have been cases that we missed, and that explanation would be one way that could have happened.
Comment and question. I was really struck by the disparity in the incidence data looking at Afro-Trinidadian patients versus African patients in Ibadan. And I thought, what could be driving this? And the experience of colonialism is vastly different in the Caribbean, in Africa, and in India, right? And particularly slavery. I believe in Trinidad was abolished in the 1830s, okay? So even the experience of indentured servitude that then brought in the Indian populations was markedly different, right, as a historical experience from the experience of slavery. And the question is, have you considered that vast, historical element, the kinds of qualitative data that might build around that, and genetically or epigenetically, thought about how to look at, well, what are potential markers of that experience, and how might that be driving the differences in different Afro-descendant populations?
So it's an interesting question. So just to go back to where a lot of this started. As I said, one of the interesting things is that the rates of migrant population in Britain are disproportionately higher among African, Caribbean, and African migrants and their children in Britain compared, let's say, to Indian and Pakistani migrants. Even though their rates are slightly elevated, certainly not as far as those of African origin. And even in Europe, you would see that in the study that Prof. Ramaswamy identified, Moroccan, Surinamese migrants, you don't see high rates in European migrants to these countries. So one of the initial hypotheses was about selective migration, and that's one of the reasons incidence studies in these countries became important. And again, putting aside issues regarding the methodologies, but by and large, at source, both in the Caribbean and in the African continent, the rates of the native populations there are certainly not as high as those in the diaspora. So going back to your question now, so it does mean that there's something about the diasporic experience that lends itself to these rates. And that's one of the things that led us down this road, as you say, of distinguishing between gene versus environment. Because one of the initial hypotheses I said was that it might be something genetic originating in the source populations, but clearly the rates there are not as elevated, so it's not that. So what is it? So if you look at the experience of the diasporic population now, and not just in the migrant population, but in their children, both second and third generation, you see similar rates. So the question then is, what is it about that experience, and does that parallel the experience you described, the whole slavery, the issues, all the psychic and ancestral and traumatic issues related to that, are those factors? And one of the other interesting things is that certainly in the Caribbean, we see inverse rates with regard to homicide and suicide. So whereas homicide rates, or rates of homicide, are much higher in the African population, rates of suicide are much higher in the Indian population. So, and wherever there are high levels or high percentages of Indo inhabitants, you have high suicide rates. You have high suicide rates in Guyana. In fact, at one point, the highest suicide rates in the world were reported in Guyana, in Suriname among the Hindustani population there, and in Trinidad. So again, so that's another question. Why are they predisposed to suicide? And the rates there are even higher than in the Indian subcontinent, although there are some high rates there as well. So there is something about the movement that creates distress. I mean, one crude hypothesis is that the Indo population tend to internalize more, and therefore would tend to suffer more with depression and those kinds of conditions, whereas the Afro population would externalize more and tend to suffer with psychosis, engage in drug use, and another interesting difference, as I say that, is that the Indo population also disproportionately represented with alcohol use, which again we haven't reported there, but which is what we found, and I mean it's been substantiated several times. So there are these differences that are, I think, if not unique, certainly more likely to present in the diaspora than they are in the home or the host countries. And again, the question is, what about the experience would predispose people to have that kind of outcome?
Sorry, I have another question. In the first part of the Intrepid presentation, there was a slide talking that was characterizing the amount of time before individuals engaged in treatment. I think like for both Trinidad and for Nigeria, it was somewhere like in the three plus years. However, in the India, it was about 7 years. And so, sorry, I'm trying to make a little segue here into my area. It made me think about cultural understandings and beliefs around psychosis, mental illness, and Professor, as you mentioned, to be sick in this gross generalization, in some African societies, like you hide, like those folks are not often walking around. They are kind of behind the shadows, especially mental illness. And so you seldom see sort of these acute manifestations in public spaces. But I was just wondering, in terms of the ethnomedical context, were you able to sense in terms of culture within India, if there was perhaps less stigma associated with mental illness, if it's in terms of sort of its connections with their spiritual system, in terms of like reflecting sort of being inhabited by particular deities, and sort of like this is actually a welcome, like they're just manifesting this particular, so of course we let them act however they're going to act because this is broadly connected to their spiritual system. Whereas I'll just speak specifically in Zimbabwe, it is immediately thought as or interpreted as a sign that something very bad that this behavior, which is very antisocial, is driven by either spiritual infraction, like not respecting your ancestors, or jealousy and someone bewitching you. Several years ago when I first started working here, I did this talk for the students. It was very, I guess, perceived as provocative, and I was trying to get the students to understand that, don't laugh at witchcraft. Like, that's really, if you have clients that believe that they've been bewitched, you need to be very respectful and understand that, it doesn't matter if witchcraft is real or not. That's not the question. But, some, in my research with traditional healers in Zimbabwe, it didn't matter if it was real or not. What mattered is that it mattered for the patients, and it had a direct impact on their care-seeking behaviors in terms of where they went first, et cetera. Fortunately in Zimbabwe, I also worked in a rural context. There was this wonderful doctor who grew up, he was Shona as well, and he would absolutely, like the patients would come and see him because they understood that he was not going to put down their beliefs that, like, okay, I think I've been bewitched, I need to go see the Nanga, and he's like, okay, you go see the Nanga and you come right back to me. And so I'm just wondering if there are any insights in terms of maybe less stigma related to psychosis within India versus the stigma, and I would love to understand your impressions of the stigma around psychoses in both Trinidad and in Nigeria. Thank you. Sorry, that was a long-winded kind of trying to get there.
Yeah, illness narrative and explanatory model, they are exceedingly very important, and I think they relate to also what Prof mentioned about whether people will even consider a condition to be in need of treatment. But that is something we've studied extensively in some other project that we have done. Ernest will probably remember yesterday I was talking about this trial that we did. I think I mentioned that to you too, Tony. So we did that in the context, and that was not which Trinidad or India were part of. So we can't really make a pronouncement on that in those contexts. But I do know that how people see illness, what their understanding of it, not just in terms of whether they will seek treatment, but soon or how early they will do so. The only way we can have a little bit of sense of that in Intrepid is that we also did a nested study of help seeking. So we are tracking when people decided to go for treatment, what made them to decide to, where have they been, and also sort of tracking the pathway of their illness, which would throw a little bit of light, but not as much as we would like, because if 70% of the people in India had not even gone anywhere, so there's not much that you can learn from. So, but it's certainly the case. And we do know that stigma is a really potent driver about whether, in fact, that is also one thing we were thinking about in India, because all of those people that we found in the informal sector that hadn't gone anywhere, some seem to have made an initial contact and then stop. So whether their experience with that first contact was what made them feel, no, this is not a place for me, I don't need it. Maybe that's it. So there's still a lot of things for us to learn about what are the things, what are the determinants or drivers of some of this behavior. But you're right, all of these things that you have mentioned are very important. And you know, for psychosis, being a relatively infrequent condition is like looking for a pin in a haystack. I mean, it's not. I mean, so really, you have 10 cases and you miss 2. That's significant, and because the only way you can actually find cases, because of the rarity of the condition, is to track where they go and all of these kind of things that we laid out, which was part of the explanation or part of the criticism we had for the sort of big WHO study that I mentioned at the beginning that was conducted many years ago, that didn't have this kind of extensive network of case finding. And so some of the things that they found in terms of the occurrence and the outcome were essentially limited to those going to hospital. And like you mentioned, one big determinant of taking people to hospital is risk of violence or fear of violence. And that is why if you then track, it's commoner among men than among women, but you have only studied cases in hospital, because people tend to be afraid of men when they develop psychotic, that, they are probably going to be, so they might not take women to hospital, but they take men there. So a lot of all of these things are very important in considering, and that's why the anthropological understanding of it is so crucial. We cannot just count cases without really understanding what are some of the ideas and some of the things that are driving it. Yeah.
Can I sneak in one last question before I know we're over time, but I was really struck by the rates of cannabis use and of course correlated with tobacco use, and as well as the physical comorbidities, diabetes and cholesterol. And so I'm a statistical geneticist, so I feel, I was excited by your last slide saying, there's more, we need to replicate this, there's other maybe methods we need to apply. And so maybe this is a question for Conrad and Tim and Marcos, thinking about our statistical genetic approaches, teasing apart correlation, causation, what are our next steps as researchers?
I'm going to need to excuse myself. I'm very sorry. Thank you.
I'll just briefly say, kind of linking Roseann's question to Professor Gureje's comments, is that if all this, important advances that we've seen in large-scale genetics research is almost confounded with, the pathways to care and how we encounter these cases, that in terms of pliometry, in terms of comorbidity, do we know actually that what we're studying is actually reflective and representative of the relationship between these disorders? As it exists in nature, as it exists, like in the world. And I'm not sure if it does. I mean, and so hence really the need for us to not only rely on these kind of convenience samples right? Where we end up with those, taking the example of the VA, where they might have self-selected for, for health service utilization there. They may not have had anywhere else to go. So we might end up seeing the sickest, and like those individuals, maybe indigent individuals. And how will that change our perspective in terms of both epidemiologically, in terms of, like prevalences, in terms of incidences? Like really it's necessary for us to anchor this in something that's really, epidemiologically rigorous. Hopefully the rest of the genetics field kind of takes, takes a hint from this and emulates this kind of work, moving forward. And thank you.
Yeah, thank
also.
You. I mean, there was one importance of studying cases, this kind of sample, is that it can allow us to sort of disentangle the understanding we have about some of these comorbidities with treatment. And sometimes we feel that, some of these because of antipsychotics, but some of these will be part of the illness itself. So that, but we wouldn't know that except we're able to study those who haven't even been exposed to the treatment. So that's part of what we think this is going to help us to do, especially also now when we look at the outcome and the 2 years, and some of them will have been treated, some of them will remain barely treated and all of that. Again, what's driving what? That's going to be quite an important way to.
Yeah, so I think on the flip side, right, the high rates of smoking and schizophrenia, I think there's some evidence of causal association of smoking and schizophrenia, but also on the flip side is the reducing side effects of medication, other effects from smoking nicotine and maybe also cannabis. That there's also some positives in from these substances.
Smoking it's an interesting one because it also does reflect the level of smoking in the community, really. Even though it may be higher among those who have the illness, but in a setting where maybe because of poverty, people can't even afford to buy cigarettes, so you may not really be able to find it in some setting. And that's part of the reason why some of the differences we find between Nigeria, India, and Trinidad is also a reflection of the social circumstances. They have free treatment in Trinidad, treatment is out of pocket in Nigeria, and so on and so forth. And so some of those things will become quite obvious as we follow the cases.
I think as well, in population surveys, it has been found that there are several people in the population who have psychotic experience hallucinations, have odd or strange beliefs. So I think another big question is what tips people over into illness? Mm-hmm. What are the factors that some people can have these experiences and never become ill?
Yeah.
But some others do. And I know the social theorists suggest that it is about social circumstances and social conditions and, of course, social determinants of health as against the illness itself or the experience of the symptoms of the illness. So I think that's another interesting, and I guess the genetic work will help distinguish or could help distinguish some of those issues.
I just wanted to add, you've been talking about a lot of risk behaviors, and within my field, there's also like the combination of smoking weed, drinking, illicit drugs, et cetera. Also, there's a cluster that also includes sexual risk behaviors, and for some, there's this added trauma as a result of not having enough resources and having to use their sexuality as a way to earn money. And so on, it's multifactorial, but I'm not saying that sexual risk behaviors are a part of that whole everyone's experience, but for some, it is absolutely in there, and I would hypothesize that especially for women.
I hope to catch a flight.
Okay, yeah, have a safe flight, Viv.
With that, thank you for our audience, both virtual and present.